the Diarrhea and Hepatosplenomegaly. May I ask Dr. Vishnu Biradar to moderate the session. And we have Dr. Malathi again on board, Dr. Girish Gupte and Dr. Rajesh Sainani on the panel.
So good evening. My job is very clear now and very easy, that we all passed the exams, exam is over, and now it's internship phase. So we are going to discuss and interact more in this particular presentation.
Good evening, everybody. Today I will be presenting infantile diarrhea with hepatosplenomegaly. And the history was a 5-year-old male child, second by birth order, born of non-consanguineous marriage, was found to have an incidental finding of moderate splenomegaly by the pediatrician during the routine examination. Going to the past history, the child was full-term normal delivery with no NICU history. Birth weight was adequate, 2.9 kg. The child was gaining weight adequately till 5 months of age. At 5 months of age, the weight was 6.6 kg, which was adequate. History of multiple admission was there in view of diarrhea. The first admission was at 6 weeks of age, when he was treated with IV fluid and antibiotic. The second admission was at 5 months of age, which was also associated with urinary tract infection, and the urine culture was suggestive of Klebsiella. USG, MCU and DMSA was done, which was normal. From 5 months onward, the child was having chronic diarrhea with failure to thrive. The weight was less than 3rd centile, with features suggestive of vitamin and mineral deficiency. By 8 months of age, the weight was decreased to 5.7 kg. The diarrhea was large volume, not associated with blood or mucus. There was no history of fever. Was treated with IV fluid, intermittent parenteral nutrition, antibiotic, probiotic supplements, and elemental diet. Stool was showing fat globule with trace reducing substance. Serum, liver and renal biochemistry was done, which was normal. Thyroid function test was normal. Anti-gliadin antibody was normal. Cystic fibrosis genetic analysis was done, which was normal. And serum immunoglobulin was showing low normal value. He was underwent an upper GI scopy and jejunal bioscopy was done. After that, he was given some medication for 6 months, during which he has shown remarkable weight gain and catch-up growth, and he was markedly improved. On examination, the child at 5 years of age, the child was conscious, oriented, vital was stable. Weight was 21 kg, which was near 50th centile, and height was also near 50th centile. There was no pallor-icterus lymphadenopathy or clubbing. There was no dysmorphic features. Abdominal examination was showing only 2 centimeter soft non-tender liver, and spleen was 3 centimeter, which was firm. Other systems were normal.
On the basis of this history, can somebody want some other parameters in the history, or you want to have a comment on this? This child, 5-year-old child with only splenomegaly, and he had a past history of chronic diarrhea starting from 6 weeks of age, which was up to 1 year of age, and then he taken some medications for 6 months. Diarrhea stopped, gaining weight and height quite well, I think so. Height was
always normal.
Okay. So can you elaborate on the diarrhea course after 1 year?
Yeah, after 1 year there was no persistent diarrhea, and the diarrhea was subsided. But there was during routine examination always the spleen was palpable, which was 3 centimeter.
Okay, so diarrhea subsided or diarrhea continued?
Diarrhea subsided.
Diarrhea subsided.
It is not clear. If you do upper GI endoscopy, take jejunal biopsy and give treatment for 6 months, I am really surprised that you diagnosed tuberculosis on the basis of jejunal biopsy. Is that right? What you are trying to hinting at? 6 months course of therapy, to my mind, there is nothing but anti-tubercular drug.
So what kind of therapy this child received?
Should I reveal now?
No.
Okay. Okay. So any other inputs from the audience?
What is the feeding history
Yes.
In view of the fact that the diarrhea has been going on till 1 year of age.
Yes.
Give us the feeding history: breast milk, top milk, fruit juices, what?
First attack at 6 weeks.
First attack was at 6 weeks of age when
Second
he
at
was
5.
on exclusive breastfeed. The second at 5 months of age when he was taking the breast milk. Apart from that, he was also receiving soya milk.
Why soya milk?
Soya milk because the mother was told by someone that because of breast milk he is getting diarrhea more.
And child continued on soya milk till 1 year of age.
The child was continued for soya milk.
Now after 1 year, and it was continued beyond 1 year or not?
Beyond 1 year he was taking all the things normally.
No.
Up to 1 year he was taking soya milk.
And thereafter he stopped.
Thereafter he has stopped.
Okay. Then second thing, fruit juice introduction.
Fruit juice was introduced after 6 months of age, but there was no any correlation between the introduction of fruit juice and the aggravating of the diarrhea.
Sugar intake.
Sugar was always normal. D-stick.
Addition.
No. No.
Okay. And what you said, you mentioned, we looked at this and that. What about the gluten introduction?
Sorry, sir?
Gluten.
Glutamine.
Wheat.
Glutamine.
Or barley.
Yeah. He has, the glutamine was introduced after 1 year of age.
Okay. And here the onset is at 6 weeks of age.
6 weeks.
I just wanted to ask, with your stool microscopy, was there? Did you say there were fat globules?
Fat globules.
And there were not fatty acid crystals.
No.
Is that right? So that points away from the gut as a cause, and so you narrow it down to pancreatic or biliary. Just to bring everybody back. So the questions about gluten and all those sorts of things are not really relevant because you're not looking at a bowel disorder.
Yeah.
What
He
are
was
the-
quite wide, normal, and he was also gaining weight normally. The diarrheal episode has reduced very much. Means he was not having so frequently diarrhea. Occasionally.
So the diarrhea is not the main
After 1
thing.
year, there is no diarrhea.
Yes, sir.
Are you clear about that, or it was in between happening?
Means it was not continued, sir.
Now, what is
Okay.
your interpretation? Mothers may say anything to you.
Mother was saying after 1 year the diarrhea was stopped.
So you also believe that?
Yeah.
Fine.
Fine. So this is the case of splenomegaly, not the diarrhea. So the question.
So the diarrhea is not in question over here. Let's move away from there. Can you just briefly show those first 2 slides again, just for the people with short-term memory like me?
No, the back.
Yeah.
Diarrhea is important.
This was related to diarrhea only, and the
Okay, thanks.
splenomegaly is incidental finding. So we are back to the approach to the splenomegaly, asymptomatic. So what are the possibilities now?
No, the immunoglobulins, he said, I believe, were
It's
low.
low. So
But
what are the
which-
possibilities?
Yeah. No, just because we were discussing diarrhea that time.
I think we should go away. Excellent. Yeah.
Diarrhea.
The, but the main problem, yeah. If I am correct, that after yeah. Yes, immunoglobulins you are
yeah, so no,
having
is there some IgA deficiency or something causing? But if the diarrhea has settled,
So
I
we
think
should not
then it sorts out all the
Profile-
problems.
profile is-
Just the profile.
So what are the possibilities of the splenomegaly without any other symptoms? So again, it's a basket where I think Dr. Malathi, you just
Yeah, the usual teaching is infections, because in this age you can have a palpable spleen, but if significant, you can think of HIV, the infections which can present. You can think of anemia itself is causing a splenomegaly. Here we are not going to think of storage disorders and all that, though the things, there's no liver. But in one thing they said there is a liver enlargement.
2 centimeter.
Whether there's an immune dysfunctions and you have a splenomegaly, I think that's how we have to approach, because we don't have anything else except that diarrhea. Because we always teach, whenever there's a splenomegaly, always look at the what's the dominant presentation? Is it anemia with splenomegaly? Is it a bleed with splenomegaly? Is it fever with splenomegaly? And then only you can come to a diagnosis. Spleen is enlarged in so many things. So if diarrhea is the dominant, we have to give importance for the diarrhea. If it's a bleed, then yes, I will look into portal hypertension. If there's fever, then I will look at infection and leukemia and RE cell. But if there's a joint, then I will think of something else. So there will be another symptom. There will be one dominant symptom along with the spleno. Otherwise, isolated splenomegaly is seen. We will leave it. We will do an ultrasound, exclude portal hypertension. We'll think of tropical splenomegaly syndrome, or we'll think of that, and we'll just watch. It could be a THAL variant, a THAL thing. We don't know if it's things. It all depends upon the associated symptom which we are going to do.
Can I ask a full blood examination and X-ray of the arms? Because Schwackman diamond would produce pancreatic malabsorption, and the diarrhea improves with age.
Any dysmorphisms?
No dysmorphism was there.
Okay, and no skeletal abnormalities?
No skeletal.
Okay. Okay, I think
the full blood count was normal, wasn't it? There was no neutropenia.
No.
So we are not gone into the investigation. So probably we are open to it. So yes. So these are the investigations. Okay.
Oh, the full blood count was not shown only. The white cell count, I mean, sorry. Okay.
Do you remember any white?
The white cell count was normal, 8,000 to 9,000. It was.
Any differentials? Normal.
In differentials also, there was 78% neutrophil with 22% lymphocyte.
Okay. Sorry.
The OTPT has gone up. AST, ALT.
So.
The liver was not enlarged.
Liver is 2 centimeters soft, non-tender.
So now it's a hepatosplenomegaly.
So it's not only hepatitis. Yeah. So
hypogammaglobulinemia with
Dr. Girish, can you explain about? Can you just comment on this?
Yeah, I mean, I think both the SGOT and SGPT are elevated. So clearly, it's a cellular problem more rather than a biliary problem, because both gamma GT, alkaline phosphatase particularly are low, and the bilirubin is not mentioned, so I presumed it is normal.
Bilirubin was normal.
And the PT is, I don't think this is very prolonged, isn't it? Is that a
1.0
normal range? And albumin is okay. So it's mainly a cellular. So something is causing irritation to the liver cells over here. It could be primary, it could be secondary. Very difficult to say, but more likely to be primary with the elevated liver functions that you see. So some primary pathology within the liver that could contribute to this, which is associated with splenomegaly and which is associated with diarrhea, which is questionable.
Yeah, Dr. Malathi, you want to make one point, any point regarding the albumin and globulin?
Yeah, the globulin appears high, but one reading, I think we should not
be
coming
carried
that.
away.
But definitely, when you get recurrent infections itself, you can get this high glob. But I think you should get your electrophoretic pattern and get one more reading, because now we've seen when you have serial readings, but definitely there's something in the liver. But I don't expect a 2 centimeter soft liver when you have such findings. See, the findings are very important. Your hand is the best probe, and we cannot just exclude that liver finding. We can't say it's only the spleen. There will be a liver in this case with such high transaminases, glob high. I think we should give importance for that liver. Then your thoughts will change.
Like Malathi said, that we have to give some importance to the diarrhea. I would still want to think, is this celiac? I know we don't know the histopathology, and gliadin is negative, but many times I think I would like to have a relook at the histopath as to, is there something?
Yeah, but only thing I think which was pointed out, that the gluten introduction.
Diarrhea is at 6 weeks. It is unlikely.
Fair enough. Unlikely. And fat globule.
So any other clues or any other differential diagnosis, or you want to proceed with the?
See, one is, if you are asking us,
Yeah.
See, for diarrhea, going on up to 1 year, thereafter it has stopped by some intervention with therapy. We are not clear. Actually, there should have been a graphic presentation, what has happened at what point of time. Anyway, fructose intolerance will be one, which you should come because enzymes may be elevated in that, and presentation may be with diarrhea actually. So that is one possibility which we should keep it in mind. Second thing is unrelated to the liver. Was the diarrhea because you have introduced, somebody has introduced soya milk? We are not sure whether there was a top milk going on and there was a milk allergy. And after soya withdrawal also, the things have gone. It is a natural history of any milk allergy which can, diarrhea can subside. So if it is unlinked, then. So these are the two, I think, DDs if we take diarrhea and liver disease.
HIV was done?
ELISA was done, which was negative.
Okay. So
I don't see much of tuberculosis nowadays, so I don't have any clue about it at all. But you have excluded that. BCG scar was there.
There was no Cox contact. BCG scar was there.
There's no history of Cox contact or anything. But I don't mean like I.
About tuberculosis, onset at 6 weeks, without intervention going off, diarrhea. Second thing, alphas would have been expected to be more rather than HGOT, IgPD. Fever should have been persistent rather than what they have shown, UTI.
But he got treated, sir. That was the thing. 6 months he received treatment. And
no, I'm more asking a question as a learning point rather than making a statement about it.
So how do you want to proceed? Proceed with the regular liver workup or? I'm asking you all the panelists.
Sorry.
CDH.
No, I think on the basis of this, clearly, since the disease is located to the liver, then you have to proceed with a basic screen of the liver function test. Apart from the liver function test, the next level of screening. So I would like to do the normal things like copper, ceruloplasmin, thyroid function test, autoimmune profile. And that's just a screening in the initial, because there are a few pointers over here, but not significant pointers where you could localize and focus and save your money on the investigations within the Indian subcontinent. So I think that's what, and an ultrasound scan just to make sure, corroborate our clinical findings and see if it tells you anything more. Those are the initial tests that I would like to do. The immunoglobulins you said were normal, weren't they? No, high. Low. Right.
Normal.
That was during the episodes of diarrhea.
Diarrhea.
But the globulin fraction is high.
This point?
Not this point.
Okay.
The globulin fraction is high and the immunoglobulins are low. Okay.
During that time.
So what are the subsets? Profile.
The albumin was low. A1, A2 was
albumin is normal.
Immunoglobulin.
At that time, when the serum electrophoresis, when this immunoglobulin level was low normal, at that time.
No. I think I'm a bit. Don't show this slide because I'll be more confused. I am a bit confused now because I'm really confused now because what you're trying to say is that
he was saying that the immunoglobulins were low during the episodes of the diarrhea and failure to thrive phase, but now these are the
so this is at 5 years of age.
At this 5 year of age.
No. At 1 year of age is immunoglobulins are low.
And after that any immunoglobulin levels?
Yeah, it was done. I will be showing in the.
Okay.
Can you do transferrin isoforms here or not?
So other pointer, probably a remote possibility because your gamma GT is on somewhat. Is it normal?
It was normal.
This
is normal. Yeah, otherwise we would have considered if we see liver and diarrhea, then PFIC type 1, although we have 2 pointers which are against, that is one is the pruritus
is not there.
Second is gamma GT is with the normal limits, we would have expected lower gamma GT in that.
Bilirubin is normal, no jaundice.
And at present there is no diarrhea?
No diarrhea.
Thank you. Okay.
Vishnu, you have 1 minute.
Bilers and chronic diarrhea. Yeah. So that one more possibility of bilar disease. Okay. So we will go ahead with the investigations.
Yeah. Now summarizing 5-year male child with chronic diarrhea in infancy treated. Now with splenomegaly and liver dysfunction under evaluation.
Okay.
So
Go ahead. Next.
So ultrasound was normal. It was not showing any hyper echo texture or anything.
So ultrasound was totally normal.
Was normal. It was only showing hepatomegaly
And spleen?
and splenomegaly.
So are you giving us the diagnosis over here by saying the ANA is 1 in 320 and the NTSMA is weakly positive? So is this is autoimmune liver disease type 1? NTLKM antibodies is negative, serum ceruloplasmin and yeah. So is that, so the diagnosis is autoimmune liver disease?
Yeah.
Is that correct?
Yes.
Do I pass the MD exam?
So this is I think this is the case where there was no clue in the history, no clue on the examination, and we just saw that there was little bit of hepatitis and done the hepatitis workup, and then it came positive.
No,
Right?
see that this is just to confuse the audience. You have started with diarrhea. This child doesn't have the correlation between the diarrhea and the ultimately liver disease. Why have you confused us? Everybody has started thinking what is the relation between diarrhea and liver disease.
Correct.
So that you don't have explanation for diarrhea. Dr. Yache is asking repeatedly, you explain what happened to the diarrhea. You don't have any answer to that. So now you should present straight away. 5 years old child presented with splenomegaly and this is abnormal LFT. What will be the differential diagnosis? Instead of presenting with diarrhea, you cannot confuse people. You give the right perspective.
Yeah. You say it was a distraction.
Yeah, actually we should not have given the importance to diarrhea. I agree totally. It is a totally distractor in this case. Probably this is a case this is the 5-year-old child with splenomegaly, with hepatomegaly, and then liver dysfunction. Correct.
The investigation was continued and the serum protein electrophoresis was done.
So are you going to tell us that what was the treatment given at 1 year, or are you withholding that treatment?
At last.
Okay.
Then increased gamma globulin was there, 30.6, which was twice the normal. Liver biopsy was done and gastroscopy was done, which was not suggestive of any varices. The liver biopsy was saying interface hepatitis, lymphocyte, plasma cell and neutrophil with rosti formation and panlobular inflammation. HAI score was 11/18 and fibrosis score was 1/6. And the duodenal biopsy was suggestive of mild villus blunting, lamina propria showing increased lymphoplasma cell infiltrate with lymphoid aggregate, intraepithelial lymphocytes were present.
Why duodenal biopsy at 5 years? Means there was no diarrhea now?
There was no diarrhea, but initially also
so again,
it was
if it is not required right now, so why the duodenal biopsy is it's just to confuse, again to add confusion.
I think they must have done the endoscopy to look for varices and probably took biopsies that time.
One point you have to explain. See, there are two distinct things. One is celiac disease producing the villus atrophy. Second will be autoimmune enteropathy. What will be the distinction between the two biopsies? So it is not enough to tell us. Tell us, is it autoimmune enteropathy or is it celiac?
Lymphocyte antibodies we don't do.
You don't know. Your TTG, IgA is normal. Your biopsy at 1 year was normal. And now you are saying this is celiac disease.
No, biopsy at 1 year was also suggestive of similar thing.
No, you said that was normal?
No.
Not biopsy. USG was normal.
Biopsy done and treated.
It was done and treated.
Biopsy was done and treated with some medication. On the basis of the biopsy only, the medication was started.
TTG was negative.
Glidin was negative.
No, glidin is not a good antibody.
So they didn't do TTG that time.
Tissue transglutaminase IgA antibodies was done.
Yeah, that was negative.
What happened to you tell us what is the structure on histopathology as far as the crypts are concerned. That may give you some clue whether it is celiac or autoimmune.
Yeah.
Is there a destruction of the crypts or there is a hyperplastic crypt here?
Is this the second biopsy?
This is the second
so
biopsy.
when the diarrhea has resolved,
yeah,
you're seeing these changes
yeah,
and you're calling it an autoimmune enteropathy,
Yeah.
causing no symptoms.
Yeah.
I don't agree.
Yeah. I also disagree.
Have you withdrawn gluten from the diet? What you concealed from us?
So what is the diet intake of this child now?
Now he is taking everything normally.
Means after 1.5 years or 1 year?
After 1 year of age.
Was he wheat of the wheat?
Wheat he is taking, everything he is taking.
But no, in between.
Before 1 year he was not taking, sir.
So you had withdrawn.
Wheat was introduced in the diet at what age?
At 1 year of age.
1 year.
Six weeks of age.
So 6.
It's
Can you clarify all this?
Next
No,
slide,
but
next
see
slide.
that
The last
to make it more interesting, he brought this case to show that autoimmune and hepatitis with autoimmune enteropathy. But this biopsy is not suggestive
sufficient
of autoimmune enteropathy.
enteropathy.
First thing, because if you say intraepithelial lymphocyte and all these features what Dr. Yacha is suggesting could be celiac disease. So this is neither celiac disease nor autoimmune enteropathy. These mild changes you get in India in many conditions, just mild villus atrophy. So this is and patient is asymptomatic. You treat with 6 months steroid and then autoimmune enteropathy cured. I don't think so. Girish, will you agree?
I am not happy with this case at all.
No,
But I think I would agree that autoimmune enteropathy children are much sick. The diarrhea doesn't resolve on its own. It just carries on.
therapy and then absolutely cure it is not possible.
I think what happens is again, your histopathologist may have interpreted this as autoimmune enteropathy, but probably you need to, because that's again stressing on what has been said throughout the meeting, that you have to make your clinical decision and trust yourself and go back, and if this doesn't match up, go back and review the biopsies and then decide what is your clinical decision of how to manage this child.
So
Last slide.
I think you also need to go back to the guy that looked at the stool and tell him he can't do his job. Because if you can't distinguish the whole point of being able to distinguish fatty acid globules from crystals is to give you a very simple way of working out the cause of the diarrhea. So you can't have, if you've got globules, then you shouldn't have a flat mucosa. You should have crystals. So the whole thing doesn't make sense. I don't like it either.
Sorry.
So what happened to this child now?
The child was actually at that time was given prednisolone for initial 3 months. He was on 2 milligram per kg per day, and then it was tapered over a period of time. And after that, the child was shown remarkable weight gain also and catch-up growth, and the symptoms were decreased also.
Now what happened to spleen, which was the main manifestation? Weight will increase because you are giving
Steroids.
Spleen is
You tell us what happened to the liver enzymes.
liver enzyme over a 6 month of period came to be normal. Now it's the normal in 43 and 40 range.
That's very good. That's very important. Not other things are important. And spleen is still persisting. It will take time. Right. Okay.
Steroid with azathioprine.
This is just a case of autoimmune liver disease.
There is no doubt about it.
Okay.
But diarrhea could have been because of UTI, could have been because of
infections,
could have been because of the soya withdrawal, soya protein intolerance, and therefore it subsides. It doesn't seem to have any link because rest of the period diarrhea is not occurring. So it doesn't seem to have any link with this disease. But autoimmune liver disease we accept, and there's a response to therapy as well. And that is type 1.
Yeah.
Type.
So
That's very good information.
So to sum up, the take-home message from this child, from this case, was that even the autoimmune liver disease can present silently. They just present with splenomegaly. The diarrhea and other distractors has to be looked in the clinical scenario. Are they fitting together or not? And you should not get carried away with the one disease symptoms that diarrhea is there, so we should club together diarrhea. So sometimes there is two different pathologies which are occurring in the same child.
And not only autoimmune, but also other disorders what Dr. Girish
Gir-
I would like to have a panel. So you should do the panel. Hepatitis C would not be that important, but hepatitis
B.
B, Wilson's disease,
So that was negative.
That is
that they
negative.
have done. That they have done. We appreciate them for that. So total panel has to be.
So without jaundice also chronic liver disease presents.
Yes, very important.
So-
Intelligence lies in diagnosing children with chronic liver disease, early phase, without jaundice. There lies the key.
Okay. Yeah. Thank you.
Thank you.
Thank you, panelists, and thank you, audience, for the active participation. Thank
Ultimately, the liver and spleen came down to normal size or not?
Yeah, that
Still, the spleen is 3 centimeter. No?
spleen is 3. It will take time, 1 year. Yeah. Time.
Faculty goofed. Faculty failed.
Yeah. Thank you.